So if everyone really put this on their calendar, they probably don't know this, but by the time the interview is finished, you will know that September is Peripheral Artery Disease Awareness Month. And we have a real expert, Dr. Kenneth Fromkin, who is with Cleveland Clinic. We've talked with Dr. Fromkin before, but it's always great talking with someone who really cares about his work, makes people feel better. And so thank you for joining us today.
Thank you. It's great to be back.
Good. Dr. Fromkin, so when they say that it's an awareness month, they have that with breast cancer, with a lot of things. What does that really mean for people?
Well, I think it brings into focus the fact that a lot of people have peripheral arterial disease, but it remains a very underdiagnosed and undertreated condition.
And how are they? Well, isn't a primary care physician supposed to know that someone has that?
Well, that's certainly true, but it's not always immediately evident that the cause of a person's symptoms are actually blockages in the legs. When a person describes to their primary doctor that they're having a little trouble walking, it can so easily simply be construed as the fact that they're a little bit older, a little bit overweight. Perhaps they have some neuropathy from diabetes. So it can really be from a wide variety of causes. Also, back pain is a big reason why a lot of us think folks have trouble walking, and for many people that's true. But what often does not immediately jump to mind is that it also could be blockages, peripheral arterial disease.
And, of course, that means that you have veins in your legs that pop out. Does that say anything?
No. We separate out the arteries and the veins. The arteries are the supply lines, and the veins are the drains. Now, disease of the veins is its own separate issue. That's probably a talk for another day. But the arterial problem is the supply line to the legs. And what happens is that just like other arteries in the body, they can be affected by atherosclerosis, hardening of the arteries, cholesterol, and plaque. And when the legs are not able to get a proper blood supply, then as soon as a person uses the muscles in the legs, they simply don't get enough oxygen, and the muscles kind of cry out for help in the form of pain and weakness.
And that's when we really have to do something very serious. So if you are referred a patient, what does it consist of for you to understand what's really necessary?
So when we get a patient who might be someone with peripheral arterial disease, we start off by just taking a good history and physical. We look for other causes of why they might be having discomfort in their legs. In terms of the physical exam, things we could notice. Early signs of peripheral arterial disease, oftentimes the hair on the legs is absent. Sometimes people don't even notice that, but that can be one of the subtle indicators. Sometimes the limbs can be a little bit cool. As we feel for the pulses, oftentimes, in fact, pretty much always, if someone has severe peripheral arterial disease, we will notice that the pulses are diminished. There's some basic tests that we can get. We can measure blood pressure in the legs just like we can measure blood pressure in the arms. And by comparing the blood pressure in the legs to the blood pressure in the arms, we can come up with a little ratio that helps us figure out whether there are blockages in the legs. When we have a high degree of suspicion, then we can start with some other types of tests like ultrasounds of the arteries, sometimes even an MRA or a CAT scan of the circulation to the legs. And that can be confirmatory.
Now, when I hear all this, it really requires someone who really is an expert, because people don't want to go through all sorts of tests when they're with someone that's not as knowledgeable as you. And I see that their one title is the Interventional Cardiology. What is the difference in that and a cardiologist?
Right. Well, an interventional cardiologist is a subspecialist who specializes in doing procedural-based things, like taking angiograms of the coronary arteries, like doing angioplasties and stents of the coronary arteries. And that is what I do. I am an interventional cardiologist at Cleveland Clinic, Florida, and in addition to working on the heart, we work on the legs very often. That's become a fairly common thing for those of us in the field.
But when we hear people have stents, it's usually they're leading to the heart.
Yeah, and this goes back to the comment I made, which is that peripheral arterial disease is often not thought of. It's somewhat underdiagnosed, and in reality, it is somewhat undertreated. You know, going back to what you said earlier, you said, well, shouldn't a primary physician be thinking about this? Well, I think that many of our primary physician colleagues do think about this, and that's a great way to start. And I think that any time someone is having a visit with a primary doctor, some of the things that should come up would be whether or not they're having difficulty walking, whether or not they have trouble with their legs. And I think that when any primary doctor hears that the patient is having trouble with their legs, a little light should go off, and they should say to themselves, might it be that this person has peripheral arterial disease? And through Peripheral Arterial Disease Awareness Month and through getting the message out like this, we're really hoping that more and more people can have that little light go on so that they realize that this is something that in many people causes them to have a lot of discomfort and disability.
So are you saying, though, that this disease is more prone in people who are over 60 and 70? Is this an age-related disease?
It is true that people who are older are more likely to have it than people who are younger, but not everybody who's older has it, clearly. It's just that when a person has lived for a longer period of time, things that take a long time to develop are going to be more developed than someone who is younger. But of course, the main risk factors for this would be cigarette smoking in the past or in the present, and diabetes. Those really do correlate rather tightly with the concern for peripheral arterial disease.
And I was just going to ask you that because it seems every physician over the last maybe 5 years that I've had on this radio show, and I've done this a long time, smoking is the most important issue. They'll say, smoking, you know, because I'll ask, is it diet, is it exercise? And I'll say, well, first of all, it's smoking. That's certainly changed, hasn't it, in the view of the doctor from many years ago?
Well, it certainly has. I think that we as doctors have known about the dangers of smoking since at least the 1960s, but I think that in terms of society at large, we're seeing fewer and fewer people smoke, and the people who do smoke are really well aware of the health consequences of it, and they're certainly aware on an intellectual level that smoking is not good for the health. But for other reasons, they have difficulty stopping and they enjoy doing it. But back in the day, people used to smoke commonly, and they legitimately had no idea that it was detrimental to the health.
Including doctors. I mean,
yeah.
I remember that. And of course, well, let's just go with this one more thing. So if someone, I've never been a smoker, but there are people who've been smokers and they've stopped smoking. And I've heard that still plays an important part in their respiratory and their other systems.
There are so many negative effects that smoking has on the body. And so stopping smoking at any stage can only be a good thing. Now, some people say, if I stop smoking, is it going to be as if I never smoked? The answer to that question is no. Certain damage has been done, but what can occur and what will occur is that from that day forward, that person will not be accruing disease or developing disease at the same higher rate that a smoker would. If a person's been smoking for 40 and 50 years and has already developed significant blockages, stopping smoking is not going to make those blockages go away, but it sure as heck will slow down those blockages from getting worse, and it will also reduce the risk of that person having a heart attack. It will reduce the risk of that person having a stroke, and it will reduce the risk of them having cancer.
Wow, that's a big thing. So that's something that people should definitely do. But and this is a strange thing. Have you ever had a patient that you have worked on and you have gotten them really in good condition, and then they go back and they start smoking?
Absolutely. Happens all the time.
Oh, it's just, and I guess it breaks your heart, but there's nothing you can do about it.
Well, I mean, there's something that we can do about it as doctors. I mean, has it happened to me? Yes. Does it happen with some degree of frequency? Yes. Because let's face it, cigarette smoking is a very addictive kind of thing. There's a physical element to it. There's a psychological and habitual element to it. People enjoy it for various reasons. And so a lot of times when they find themselves with a very serious health problem, like a heart attack or, let's say, bad peripheral arterial disease, and we go in and do something, for a certain period of time, that person is highly motivated to not smoke. But then they start to feel better and life kind of intervenes and things are back to normal. And before you know it, they're kind of back to smoking. So I do see that. Now, some doctors actually won't even go ahead and try to fix blockages in the legs if they feel that their patient is going to continue to smoke.
Really?
Yeah. And the reason that they feel that way is because the risk of the blockages returning is so much higher. Now, I think that kind of attitude is decreasing. Certainly in my practice, I would never refuse treatment to someone who smokes. I just say it in a different way. I tell them directly. Some doctors might not even offer you this procedure. I will, but I'm going to tell you right up front. If you choose to smoke, or if for some reason you happen to revert to smoking, you need to be aware that it's probably going to undo all the work that I just did.
You would think that someone that goes through what you have to do, it's not pain-free, and there's a recuperative, time limit and time period, and that they would go right back to that. I mean, it is hard I am a non-smoker, and so it is hard for me to imagine that. But yet, I would think that you have great places for you to send them for programs.
Stopping smoking is very difficult. We have some medications that help, and there's some counseling programs that help, and we try to use them whenever and wherever we can. But it is a very difficult task. And the only thing I will say is that we're very fortunate in that every year that goes by, we are seeing fewer and fewer people smoking. It's becoming increasingly uncommon, and it's becoming increasingly socially unacceptable. People can't go into restaurants these days. They can't go here. They can't go there. It's really becoming quite a task for someone who wants to smoke to even be able to do so outside of their home.
Well, I just have to say that we have a great administrator, Dan, and I don't know if you got a chance to talk to him, but he smokes, and he knows that he shouldn't smoke, and he doesn't smoke in the office and all. And I said so many things to him. He's such a smart gentleman, and he just can't break it. And I think to myself, because I have a friend that has lung cancer now, I say, are you kidding? I can't imagine someone as smart as you. So, I guess he'll have to do it when he can do it. There's nothing we can do.
It's not the intellectual side of our brain that
right.
causes people to make this decision. And we as doctors, we're not here to yell at people or to lecture to people.
Yeah.
We are legitimately here to try to help them. So, first of all, we tell them what they already know, which is that it's beneficial to stop smoking. But I think that the important step is that the patient shouldn't feel that the doctor's yelling at them or being judgmental. The patient should feel that the doctor is legitimately pointing out to them something that could be a problem, and that they're working with the patient to really try to offer a solution to help them stop smoking. And that's certainly how I try to be with my patients. I'm not passing judgment. I'm not yelling at them. I'm not lecturing them. I'm legitimately attempting to help them stop smoking with variable degrees of success.
Yep. Well, it's admirable. And let me just say that Dr. Kenneth Fromkin's been with Cleveland Clinic for a long time. I know we had him on our show once before. And, excuse me, he's an interventional cardiologist. We've been talking about peripheral artery disease. It's the awareness month is September to make sure that you know about it and you question your doctor if you have any of the signs and symptoms. Also, ClevelandClinicFlorida.com is where you will find a lot of excellent doctors, of course, including Dr. Fromkin. And I think it's really important maybe that we go over, I know that you've had a lot of awards. I must say that you actually even you've done, is it a patent that you've done?
No patent.
It's an innovation, it says. There's some things that you've done that were very, very, very high-tech.
Well, I think that the field that we work in, as an interventional cardiologist, by its very nature, we're working with equipment, we're working with techniques and procedures. I'm not going to put myself out there as having invented or first thought of any of this, but it is true that we do routinely quite a number of complicated procedures, both in the legs and in the heart. And my particular specialty, my area of interest and my passion involves difficult, complicated interventions, both of the heart and of the legs. I really enjoy the more advanced, difficult kinds of things. The easy ones, anybody can do those, right?
Right. And before you go in for a procedure, it's like kind of a lot of us in our different fields, we kind of map out a plan and we figure out what we're going to do. What do you do as a cardiologist or an interventional cardiologist before you have a difficult situation? Do you design something that you know how you're going to do it? Do you discuss it with your colleagues?
Well, I think like anything else, we try to plan. Nobody wants any surprises in the middle of a procedure. It's very important not to rush into things. One should never have a procedure or an operation before due diligence has been performed. You really have to think about it, and you have to make sure that you've got the diagnosis correct. You have to work within a larger team structure, and that's one of the big advantages of working at a place like Cleveland Clinic. We have a large group of people who do work together. I can walk down the hall and talk to my colleagues who do echocardiography or who deal with the electrical aspects of the heart. I can talk to my colleagues in vascular surgery or radiology or vascular medicine, all of whom can add a little piece to the puzzle. In the final analysis, I can be very much like a technician, but you need much more than just a technician to really accomplish the task of properly diagnosing and treating somebody's disease.
Do you use robotic surgery in any way?
Well, I'm not a surgeon, and I don't use the robot. Certainly some of my surgical colleagues do. But the procedures that I perform are similar in the sense that they are minimally invasive and that we do all of our work through catheters. We're not making incisions. We're not cutting and sewing. I am not a surgeon, and I do not do operations. And yet we're working inside the body. We look at what we're doing on the X-ray machine, on the fluoroscope, and we basically watch, taking X-ray movies of the arteries as we work on them and fill them with contrast. And when we're all done, sometimes the patient comes back and they say, "Where exactly did you enter my body? I don't even see it." Of course, other times they're a little bit black and blue, but it is very minimally invasive.
Wow, that's quite an explanation. And how long has interventional procedures been around?
Well, the first angioplasty in the United States was done in the early 1970s, simultaneously in New York City and Seattle. It was kind of interesting. And I'm very fortunate that I actually trained with one of the folks who did the first angioplasty, not in terms of the physician, but interestingly in terms of the nurse. And that person who assisted the first angioplasty also worked at the institution where I trained up at Cornell. He had moved from Lenox Hill. And I was really very fortunate to have gleaned some of his insight, a person from the days of the giants. But we've been doing these procedures since the 1970s, and like anything else which is technical, the longer we do it, the better we get at it, and the equipment and the techniques just improves. If you think what your personal computer or your cell phone looked like 10 years ago, 15 years ago, or even 5 years ago, there's a huge difference. And I think that the same can be said about specialties like mine, where we do technical things and we depend on having slick equipment from the manufacturers.
You are so enthusiastic. I remember this from last time. You absolutely, and I don't know if you know this, but we're going to put your recording, this interview, on YouTube, and I think I have your picture from before also, and we're going to use that. But when you were going to school and you had to decide what you wanted to be, who made that decision for you?
Well, I made that decision for myself, and I tell you, if you're going to go into medicine, you better make sure that it's going to be your decision and not someone else's, because this is not a job, it's a lifestyle. But I certainly don't regret it, and I really do enjoy what I do, and I really do have a passion for doing these kinds of invasive procedures. I really genuinely get a kick out of doing them, and I love the fact that we can help people. And as much as I love heart procedures, which of course is my bread and butter as an interventional cardiologist, and as much as I love them, I love the peripheral arterial procedures even more. There have been so many people who've come to my office and they really have disability. They cannot walk, they can't do this, they can't do that, or even people who have been told that they might need an amputation or who are on the border of needing an amputation.
Really?
And as the result of what we're able to do, we can either kick that can down the road or possibly even eliminate that outcome. And it's really very gratifying when you have a case like that.
Once you have performed this, does it come back again?
It can. So when we work on blockages below the leg, in the leg, but below the belly button, the higher we are, the closer we are to the upper half of the body, the less likely these blockages will be to return. So if we're talking about something, let's say, near the hips or in the very upper sections of the leg, we're probably saying 70 to 80% chance that that's not going to come back. As we get down farther down by the knee and below the knee, the chances of return are higher. But sometimes people need more than one procedure. And look, if a person can't walk and we can do a procedure for them, allowing them to walk, and 3 or 4 years later it means that they need another procedure, most people would be fairly happy to accept that as a trade-off.
I would say that's very, very true. And what's the recuperative period? I think you said that it's not too bad when you do this interventionally compared to if you actually had surgery.
Sure. When we work interventionally, 9 times out of 10, we will send our patients home on the very same day. I tend to bring my patients in the morning, we do our procedures, and as long as everything goes smoothly and the patient tolerates it well, they go home. Now, of course, a lot of our patients have a lot of other medical problems. We're dealing with populations who are older, who have diabetes, who have heart disease, who have cerebrovascular disease. They're often very heavy smokers and have lung problems. So it's not terribly uncommon that we have to be a bit more cautious and that we would need to keep them overnight. But if we're talking just about the procedure itself and you get all that other stuff out of the equation, those folks go home the same day.
That is preposterous in a sense. They go home, but is everything wrapped up? And
No, we're not doing operations. We basically insert a catheter. Let's imagine I wanted to work on the left leg. I would in most cases be inserting a catheter kind of by the right hip into the artery on the right hip, and we'd go up and over. And when I'm all done, if you looked at the leg that I worked on, which is the left side, it would look exactly the same as before because I made no incisions in it. I did not even make a puncture in it. The only thing that one would see would be that on the right leg there's a tiny little puncture site that we usually put a Band-Aid on.
Well, okay, and so you're using a computer. I mean, it's very important so you understand where you are putting this catheter.
Right. Well, actually, we don't use a computer, but we do use a fluoroscope, an X-ray machine. And as crazy as it sounds, it's really not that difficult. There is one very large artery, which is the femoral artery, kind of near the hip area, and we very carefully insert our catheter into that artery, and under the X-ray, and through our knowledge of anatomy and then watching on the screen and seeing where it's going, we direct our catheters through manipulations of our hands to where they need to go. Our catheters have all the right shapes that let us get there, and it does require a certain amount of manipulation, but as the old adage says, it's not brain surgery.
It's not brain surgery. And I have to tell you that we have an advertiser. It's called Science Care, and after listening to them and knowing them for a while, my husband and I are definitely going to give our body to science. That's what we're doing. We don't. And I was thinking about you as a physician. Did you have when you were first going to medical school? Did you have a body that was yours, not your body, but you had something that
Sure.
that you practiced on, and it was important to you, wasn't it?
It was very important to us. In anatomy class, there was a group of 4 or 5 medical students, and we did have a body that we would work on. And as many computer simulations as there are, and as many textbooks as there is absolutely no substitute for hands-on. And I think it's really a very valuable gift when somebody chooses to do that.
Yeah, I would think that also, because that's when you get to do what we talked about. Now, at the time, though, you were just starting, so you probably didn't know which area, what focus you were going to be,
no,
right?
No,
you were just
I didn't know, and not only that, but when it came to anatomy, all those wonderful things that people have now, we didn't have. And today, if you want to look at anatomy, you can basically just pull up on a personal computer or even on Google, and you can take virtual tours through an individual's body. You can fly through the bloodstream. You can see things in 3 dimensions, and this way and that way. But I'm probably one of the last generation that actually used something called a book. So yeah, the body, the anatomic donation, the body was even more important for us than it is for the current generation. But as I emphasized, there's no substitute for the real thing. You can look at all the computer simulations you want, but when it comes down to it, it's doctors and patients.
Right. And before we let you go, I want to talk about what a stent looks like. What's the material, and how does it go in? How do you do that?
So the stents are made of different metal alloys. Some of them are good old-fashioned stainless steel. Honestly, we don't see too many of those anymore. Others of them are more newer alloys, things like cobalt chromium. There's an alloy called nitinol, which is a mixture of nickel and titanium. Some of these stents actually will remember their shape, so that you just essentially unleash them from their package and they pop right open. Those are the ones that are made of nitinol. Others of them are put on a balloon, and then when you inflate the balloon, the metal stretches and then stays in place after the balloon has been removed.
I wish that I could inflate the radio time, and we've just run out of time. And it's always so interesting when I talk with you. You really are quite articulate, and I really do appreciate you taking the time, Dr. Fromkin.
Thank you. Thank you so much.
Thank you so much again.
All right.
Bye.
Bye-bye.